the that was really the crux of the whole thing.
Yeah,
And are we ready to go live, Kuntala?
Yes, yes, sir.
Yeah. So allow me, ma'am, to introduce you to the audience.
sure.
Yeah. Very good evening. Welcome all the delegates present here today for the sixth episode of Brain Mantra. Brain Mantra is brought to you by Zuventus, which is the makers of Brain Max. And I take the pleasure and the privilege in introducing once again the eminent speaker for the day, Dr. Gajre. And Dr. Gajre, for you all, needs no introduction. She is a practicing pediatric neurologist, epileptologist, and developmental disorder specialist, practicing at various hospitals in Mumbai. Dr. Gajre is a full professor of pediatrics at LTM Medical College, Science. And Dr. Gajre, over the years, she has done various roles with an unparalleled teaching experience of 26 years, having guided fellowship trainees in pediatric neurology and epilepsy, learning disability, and developmental pediatrics. She is also a member of Indian Academy of Pediatrics, Society of Developmental and Behavioral Pediatrics, to name a few. Dr. Gajre has been a principal investigator in 3 international trials, 5 national trials, along with being a guest lecturer in more than 30 seminars and 60 to 70 poster presentations in international and national conferences. And also, she has 56 publications to her credit, which includes 22 international, 34 national, and also has authored chapters in 6 books. With this, ma'am, we welcome you to the sixth episode of Brain Mantra, where you will be taking us through the topic on developmental disorders and delays. Over to you, Dr. Gajre.
Yeah, thank you for that wonderful presentation. And today we come to the end of our series. Today is the last lecture in our series, month-long, about 3 months. It was spanned over from October onwards, and it's been a pleasure to be associated with Zuventus for this. It was a unique, as we were discussing earlier, this is a unique concept, and I would love to have feedback from the attending doctors, either on my email ID or with the Zuventus team, that how did you find it? Do you find it useful in practice? And would you want, in case Juventus wishes to continue with some other kind of series, what would be your inputs? Because your inputs is what is going to guide the next, next formula for, or the formulation, as we call it, for the next lecture series. So now today's topic, we are going to end with developmental delay, which is such an important kind of a topic, and we see it so routinely in practice. So we just go to our previous format, that we will talk a little bit on what is the definition of developmental delay, how does one tackle it, and what is the approach in OPD practice. And then we will end with a case of developmental delay and approach. And the second case would be on a developmental delay mimic. So what is a developmental delay? So developmental delay is when the milestones are below the mean of -2 SD. And we know we are so well versed with SDs and Z scores and percentiles. So in this case, -2 SD means below the 95th percentile for the age appropriate standardized norm reference test. And in one or more domains of development. And we know that there are 5 domains of development: motor development, which includes gross and fine motor; language and speech, which includes receptive language, expressive language; cognition or intelligence; personal and social domain; and also activities of daily living. So these are the 5 domains. So in any of the domain, if it is less than -2 SD, that is either on the higher side, the 95th percentile, or the 5th percentile, the lower side, so less than the 5th percentile in any domain or in a combination of these domains, 5 domains, is when we call it as a developmental delay. If the delay is present in any two or more domains, then it becomes a global developmental delay, right? So here we come. So now what is in developmental delay? The other important should know is what is the DQ or developmental quotient. Now, how does one calculate a developmental quotient? So on the history, one needs to calculate a developmental quotient separately for each developmental of the 5 domains that we saw, right? And so the developmental age The quotient is calculated by the formula of developmental age depending on the chronological age of the child into 100, right? And so the developmental age, how does one know? It's on purely on history and observation, depending on when the child, in case of motor, when the child started to sit, stand, walk, etc. Language, when did the expressive language come? When did the understanding come? In social areas of play, etc. ADL in terms of, whether the child was continent, when did the child attain continence for the bladder bowel. So depending on those areas, one comes to a estimation of a developmental age, right? And then the chronological age. And we know in preterms, that is children with gestational age less than 37 weeks, 37 to complete 38 completed weeks, we need to calculate the chronological age as up to 1 to 2 years of age, right? So corrected age. So depending on that, in 200 will be the developmental portion. So in neurotypical, that is children who are growing normally or age appropriate, then the chronological age is equal to the developmental age and the DQ quotient is 100. So when you have a DQ quotient of less than 70, this is known as a developmental delay. And as I said, that the decay has to be estimated separately in each domain, as well as it is in case if it is more than 70 or it is near normal, then you can get a give also a global DQ. Now, coming to the global developmental delay, if there is a delay in more than or equal to two of the five domains, then you call it as a global developmental delay. A global developmental delay signifies either a global etiology for the developmental delay, and it is more sinister in its presentation and in its prognosis. Now, before we go on to the case and the screening, there are some things that we should know the terminologies when we deal with a child of developmental issues. One is developmental dissociation. So, dissociation means that among the five domains that we just came to know, the motor, the language, the social, the activities of daily living, ADL, as well as cognitive, of these five domains, if there is a very stark difference of -2 ST in two, any of the domains. So if what I mean to say is either one or two of the domains of the five domains, there is a stark difference in the rate of development compared to the other domains. In other words, if you look at a child with autism, the motor domain will be absolutely may be age appropriate, okay? But the language and the social domain will be delayed, whereas the cognition and ADL may be age appropriate. Also, if you look a child of a pure motor delay because of a neuromuscular cause like spinomuscular atrophy, the motor delay will be totally less than 70 ST. So there's a stark difference in the development in the motor domain, whereas the cognition, the personal, social, and the language domain may be age appropriate. So one has to know about the terminology developmental dissociation. This is what we call as a dissociation. Developmental deviance. We know that development, there are 6 to 7 rules of development, and development is a sequential process. So deviancy means that in that sequence of development, if there is, it occurs beyond it is not a sequential development, right? So supposing, but it is also considered as an atypical variant. So we know that the child has to have head holding, then sitting, then standing, then walking. But say in certain children, which are known as bottom shufflers, they just move around instead of standing with support, instead of moving around like that, they become bottom shufflers, and from bottom shufflers, straight they start walking. So this is a deviancy from the normal sequence, but it is not very significant or a red flag to consider as a developmental delay. Then we come to the third terminology is developmental regression. So in the trajectory of development, if the child was developmentally normal, developing normally, and suddenly the child regressed or there is a loss of previously acquired skill, then that is a very ominous and sinister kind of a or a very red flag, where it suggests that probably we are looking at a neurodegenerative condition. And we know that neurodegenerative conditions are not very amenable for therapy. So how does one detect developmental delay? So there are two processes that by which one can detect developmental delay early. One is the process of developmental surveillance. This is what we, as general pediatricians and not primary care clinicians, usually do, where we do an informal and flexible ongoing assessment of the development of the child. Typically, when the child comes in for a routine, either for the immunizations or say for a routine follow-up, or say a mild cough, cold, and these kind of conditions. So how do we do that? We do it through history taking, and more often by observing the child. We maintain a record. We keep a record of the head circumference, the height, weight, etc. And that is how we do it. And on a dynamic basis, we attend to the concerns of the parents when they have some certain problems or they have certain questions with it. So what the surveillance really requires, so there's nothing wrong with doing this kind of thing, but what it requires, it mandates, in fact, if we are doing this informal, flexible kind of an assessment, it mandates, and it is also, logical that one should be in close, continuous contact with the parents. You can't have these parents coming in once after birth and straight at 9 months, and then, very erratic kind of follow up. That way, it does not work. And we know that especially in the metros, parents kind of seek multiple doctors' opinions. So maybe this kind of a surveillance may not work very well in modern practice. So the other way, which is really what we are moving towards nowadays, or IAP and various bodies are enhancing and emphasizing on this, is developmental screening. Now, what do we mean by developmental screening? So in developmental screening, we proactively administer the child standard test at certain ages to identify the child early for a developmental disorder. And why are we so much behind this early identification? We know the concept of neuroplasticity, that these children have a very neuroplastic kind of a brain. And so then we know that, if we kind of pick them up early, then the early intervention, they can almost have a near normal life pattern later on. All right. And so developmental screening is definitely superior to the surveillance. And the screening, it just doesn't stop with the screening. If a child during screening, if you find that he fails the screening test, then the child needs a close follow-up and an additional diagnostic test before we put him for assessment. So you have a objective measure that this is where the child was, and after therapy, say after 3 months, for the therapist as well as you as a doctor who's at the center of the piece of the whole therapy program, you know where the child has come so far. So going to my next slide, when do we do the screening? So as I said, in screening, we do a proactive measure of doing some standardized tests to pick up developmental delays early. So there are two things, and American Academy of Pediatrics as well as Indian Academy of Pediatrics have more or less, thought of similar ideas or similar ways of doing the screening. One is at 9 months. So we have a little range of 9 to 12 months. So plus or minus 3 months is what is the range given. So 9 months, at 18 months, at the school entry time, and at 4 to 6 months, one additional time is 4 to 6 months for high-risk infants. So in case of high-risk infants or NICU graduates, one can do it at 4 months of age. In the rest of the full-term babies who were neurotypicals and didn't require NICU care or special care during their early years after birth, we can do at 9 months, 18 months, school entry, that would be 5 years. And at AAP recommends the third at 24, a little earlier, 24 to 30 months. So what are the tools for screening? AAP recommends PEDS and ASQ. PEDS stands for Pediatric Evaluation Developmental Scale. This is a free scale. It is like a 15-point questionnaire which you give to the parents. They screen the questionnaire and then you have a look at the questionnaire along with your observation. ASQ, which is Ages and Stages questionnaire. These are different ones. And this comes up right from young child to up to 4 to 5 years. You have a questionnaire as well as observation. This is usually a paid kind of a test which is there, available. In terms of Indian tests, you have the TDSC, which is quite commonly used in India, and you see it commonly in our pediatricians, our patient files that we give. Usually on the right side or the left inner side of the file, we would have the TDSC. So TDSC stands for Trivandrum Developmental Screening Chart, and it is up to 6 years of age. It takes 5 minutes to administer, and it is pretty easy. It is pretty visual, and it's like a visual marker for the parents also. RBSK, that is Rashtriya Bal Seva. This is also, there is a chart for it. Government of India also has charts by the RBSK, and it assesses for all the domains of development in addition to vision and hearing, and it is up to 6 years of age, and it takes about 10 minutes. The other thing that we should be aware of is the GMCD, that is the international scale for child development test. And now these are scales which are developed in Turkey and now adopted by the UNICEF. And there are a lot of training programs which usually happens on GMCD. It is a wonderful tool. They are trying to use it for by the Anganwadi people, and it has a tool not only for on the history, on the examination, but also it tells you that supposing if there is a delay, immediately you can, tell the parents that what can they do as parents for, say, for that particular delay. So if there is an expressive language delay, parallel talk to the parent, showing pictures, how to read to the child. So that is inculcated. So once one does the program, it is a day program, 1 day program. Once you're trained in it, you also get a chart in how to assess these children and how to monitor them and what is the further therapy that you can do at your level. So this is a slide on the GMCD. Unfortunately, it's not opening. The other thing is what is the IAP MCP card, that is a Mother Child Protection Card. It is a simple card and it is community based, and it is usually it is encouraged by the to be used in the community by the ASHA workers for all children less than 3 years of age. It is a comprehensive card in which it also talks about the neonatal care, it talks about immunization, the young infant child, feeding, as well as growth and development. It is interesting that earlier when we had these cards, it was the development was more focused on motor domains, but now it is modified to see that it is also focused on the language and the social domain because of the rise of autism that we see nowadays. So now coming to that, we will go to our cases. So we have the first case where you have this 4-year-old child with cerebral palsy who comes to you in your clinic for the first time for a routine visit. Okay, he's walking with the help of leg braces and a walker, and you find that his speech is slurred, and he's able to talk, but he talks in short phrases, which should be, say, which is acceptable for a child of 2 years. He has never been hospitalized and he does not have any swallowing issues. He began walking at 2.5 years of age, and he's unable to take off his clothes and use the toilet without help. So he has this he's able to communicate about the toilet needs, but he's not able to use it on his own. So he's ADL dependent, right? So on examination, so now from the history, that he is motor wise, also he's dependent on orthosis and appliances. His speech is about for a child of 2 or 2.5 years of age. You find that he has the good part is that does not have any swallowing or eating issues, and his motor was delayed, and he is also ADL dependent, right? Now, on examination, you find that the boy has only a little bit increase in the tone in the upper limbs, but he has definitely more increased tone and brisk reflexes in the lower limbs, right? And but his coordination is not bad, his fine motor coordination. So now he's a 4-year-old child, and already he's got developmental delay in almost all the domains, and he has probably diplegia because the lower limb tone is more than the upper limb. Any child with developmental delay beyond 3 years of age, we would call them as a child with cerebral palsy, right? So we know that this child is a diplegic cerebral palsy from the history itself. Now, our question is, how would we approach this child? Okay, the diagnosis is done. It's already been investigation. Further, what you can do for this child in the OPD. So these are certain best practices that one can do in office practice for a child with cerebral palsy. First of all is history taking. History taking to look at any identifiable risk factor. So why we are doing this? Because we want to know whether this is a cerebral palsy mimic. Okay, so you could have, there is something like just as we saw in the previous lectures, there is autism mimic, LD mimic, ADHD mimics. Similarly, you can have cerebral palsy mimics also. So to differentiate between a mimic and the actual condition, one has to do what we have been trained to do. So first is history taking to look at the risk factors. Secondly is a neurological examination, a standard motor assessment, neuroimaging if required, and one rules out any alternative diagnosis if you think if it is a cerebral mimic. Now, coming to the risk factors for cerebral palsy, we want to know whether this child was born preterm. We know that the risk for cerebral palsy, if it is a 28 weeker, is 10%. If it is between 28 to 31 weeks, it is 5%, and 31 to 37 weeks, it's 0.7%. Now, these are all international figures that I'm quoting. Now, if there is encephalopathy in a full-term baby, the risk is very high. It is 12%. And how does one know whether the child is encephalopathic? First of all, we are not asking for the child, whether the child was unconscious or altered sensorium. That is the severest form of it. But how does one look at encephalopathy, especially in children who are born at home or maybe who have not received tertiary care and ICU care? Is one ask only for two questions. In the first month or of the baby, when the baby was born, or in the neonatal period, how was the sleep pattern? Did the child sleep well, or was he irritable? And irritable, consolable, or just irritable? And the second is the feeding history is of utmost importance. How was the child feeding? So commonly you will see babies say born in at home, and you have no idea whether the child has cried or not cried. And when we ask for this history of encephalopathy, they will say that पहले महीने में दूध बराबर खींच नहीं रहा था, इसलिए हमको बॉटल का दूध चालू करना पड़ा. So there is this history of encephalopathy definitely in these babies. So that is what you ask for, the feeding history and the sleep pattern, right? Now, if we were to do an MRI at least in the newborn period, or say about a year later, what are the sites that one would say that this is probably secondary to HIE changes? Whether when there is a gray matter injury, when there is PVLs or periventricular leukomalacia, if there is a malformation, intracranial hemorrhage, infection, or some non-specific findings. All these point out to a risk factor for probably a cerebral palsy. Now, let us look at this classification. It looks like a very busy slide, but it is not, and we'll go through it to know what are the subtypes of cerebral palsy. So if you see that there is increased tone in one or more limbs with this child had, then we look at whether both sides are involved. If both sides involved, then we would say it's spastic bilateral or spastic unilateral. If the tone is varying, that means जब भी हाथ लगाता है बच्चे को या ना when the child is sleeping the tone is normal. As soon as the child gets up the child becomes stiff or doing any movement, okay, the child becomes more stiff or he has more of dystonia. Then let us see how we will come to the classification. So if the tone is varying, then it could be a dyskinetic CP. In dyskinetic CP, you have two types. This tonic CP is the most common type, in which there the tone, when the activity is reduced, the tone seems to be increased. And in the chorioathetoid form of CP, which is again not so common, you see increased activity, and with increased activity, the tone is decreasing, right? And then there are these cases where you cannot classify whether it is really dystonia or that. The commonest presentation is dystonic spastic that we see commonly. And then, of course, the spastic unilateral form is more common. Then whether there is generalized hypotonia with ataxia, again, it could be an ataxic type of CP. So chorioathetoid ataxic CP is not very common. And usually when you have these kind of presentation, we should also look actively for a CP mimic. Now, this is the functional classification of cerebral palsy. And we use this more commonly because at the end, after the diagnosis is done, you want to rehabilitate the child such that he becomes a functional member of the society. So it is more important that we are aware about these functional classifications so we can work in tandem with the therapist. So the first most important is the GMFCS, and that is how we've been trained, you know, during our MD exams or any of our exams, qualifying exit exams. Cerebral palsy is always a long case. And so we've been trained to uh, stage the cerebral palsy as per the GMFCS. So this talks about the gross motor because you know that locomotor or walking abilities of utmost important in these children for further functionality. But the other important classification is the manual ability. What about the bimanual fine motor function classification? So this really looks at the grip and the functionality of the hand. It is so important, you know, whether the child can eat on his own, whether they can write on their own. Then the other thing is the communication function. And we saw that this child had slurred speech. This case which we presented earlier had a slurred speech. So how is the communication of the child? Is the child able to talk, or does he need alternative ways of communication? What about the eating and drinking ability of the child? So that is measured by the EDAX classification. And we saw that this child had no swallowing or eating problem. Then the last classification is a visual functional classification system. All these classification systems available on the internet. So the most common one is the GMFCS because, and in this you have 5 levels. And in level 1 is independent ambulation, ambulation with limitation. Level 2, level 3 is ambulates with walking aids. So our child was level 3, ambulates with walking aids. Level 4 is independent with powered mobility, that is using wheelchair, and dependent level 5 is non-ambulatory and bedridden. So the most important level is the level 3. And with infections, these children can go from level 3 to level 4, from 4 to 3. These are the very important level, right? So your or our mediation can make this child from level 3 to level 2, right? So these, whenever you see a child of cerebral palsy and you classify him at level 3, he becomes like a red flag for you that you need to really acutely follow up this child because your intervention in any form, small interventions will also matter greatly compared to a level 1, level 2 child. So type of CP impacts. So we know that this is the topographic definition or classification of CP: hemiplegic, diplegic. So in diplegic, usually they have a better outcome. So you can see that 98% of the diplegic CP are usually less than 3, 1, 2, or 3, and 4 and 5 is pretty rare in them. So coming to what is the algorithm to investigate in a child of CP? As we said, history for the red flag signs, the examination for to see about the tone examination, to look and classify topographically what is the type and the distribution of CP. You confirm out that this is not a progressive disease. We know that CP is of a non-static kind of a thing, and it's never progressive in state. But sometimes in also saying that, having said that, in puberty, the tone can vary, right? Now, we also look at associated comorbidities. As we said, in all neurodevelopmental condition, associated comorbidities is almost always a rule and never an exception. So what are these comorbidities? In vision, hearing, speech, language, feeding, swallowing, and sleep disturbances. If you think there is a suspicion, then please go ahead and do an MRI. And after doing an MRI, try to correlate it with the type of CP. So about a couple of months back, I was referred to this 5-year-old child with dyskinetic kind of a CP or chorioattitude type of CP. And that was immediately a red flag that whether this is a CP mimic. She has been to multiple neurologists across the city of Mumbai, and they had done an MRI. Now, the MRI which was done was totally not correlating with the type of CP. Now, with the chorioattitude type of CP, you would expect that the basal ganglia and the striatal areas would be involved. But this child had cortical matter involvement and not what you would expect in the chorioattitude CP. And then when I went ahead and convinced the patient for a child for some genetic test, etc., to rule out CP mimic, it was what I had suspected all along. So it was a mimic of chorioattitude CP and presenting as a chorioattitude CP, but actually it was a genetic condition which was presenting like that. So it is very important that you just don't stop at the MRI, but think that whether that MRI is correlating with the topographic distribution and the diagnosis of CP. So as I said, if there is a malformation with this case had, which I talked to you about, we did a genetic test and this. And if there is a stroke and we see a lot of natal strokes, etc., then do screen for coagulopathy. If the MRI is normal, do consider genetic testing or metabolic testing. So red flag for CP mimics: absence of any known risk factors, which we just saw. If there is family history of progressive neurological diseases, if there is neuroregression in this child, and if the tone is changing or progressing with time, the milestones are getting lost or something like that, or if there is intermittent deterioration, unexpected focal neurological sign, normal MRI, dysmorphism, involvement of other systems like hepatosplenomegaly, immediately there should be a red flag that your antennae should go up, that this is probably a CP mimic. So the commonest question that the parents ask is, when will my child walk? And I would like you all to take a screenshot of this slide, because this is our standard answer to that. So I usually tell them, if your child can sit at 2 years, he's likely to walk by the age of 6 years. If your child cannot sit but roll at 2 years, then he may walk at 6 years. But if your child cannot sit or cannot roll over at 2 years, then he's unlikely to walk at 6 years of age. So practice points in CP that I want you to emphasize is: be mindful of the red flag signs when you're reviewing a child with cerebral palsy. MRI can evolve with time, and sometimes, and especially like this case that I talked to you about, the chorioattitude cerebral palsy, sometimes you may need to do a repeat MRI and see whether there is a change or whether this is really what it is and why it is not fitting in your topographic classification. And if your MRI is not concordant with the history, then definitely one should think of a CP mimic. In all cases of dystonia, in the UK especially, a trial of DOPA is warranted. In India, we are more reserved about using DOPA. Only in CP mimics we generally give, because a lot of our patients, we are still struggling with neonatal hypoglycemia or neonatal, birth injuries as a cause of cerebral palsy. Whereas in Western countries, you almost never see those kind of cases. So now this is another interesting case. You have so this was this case that we had which we started off with. This 4-year-old child who has GMFCS 3 level because he's using the leg braces and walker. His language is about 2.5 years of age. He is ADL dependent, and you find that he has diplegic CP. So how would we one categorize? So we know how would we approach? So we know that there is diplegia because all four extremities are involved with greater involvement of the lower limbs. And generally, as most children walk by 14 months of age, this child's motor DQ is so 14 months divided by his current age, which is 30 months. So his DQ is about 47% and his GMFCS level is level 3. This is how one would enter in their clinical notes that this is what is the level. And as I said, GMFCS3 is like a thing that you should always write in bold that you need to follow up this child more closely and see that he doesn't go to level 4. So this is another case. There are these parents who get a 2-year-old to you for the first time, all right? And this child is born through uncomplicated pregnancy and delivery, and her neonatal course was uneventful. She sat without support at 8 months, so that is not too bad, about 2 months delay. Pulled to stand at about 12 months of age. Again, 2 months delay there. You would expect like a 10-month, but all right, that is 2 months is fine. Walked since the last 1 month, so that is quite significantly delayed. So walked at 1 year, 11 months. She has a 10-word vocabulary and is able, so that is also a little delayed because you would expect a 2-year-old to talk in 2-word phrases, right? Speech. Able to drink from a cup and feed herself with spoon. So that is fine motor seems to be not too bad compared to her language is gross motor. The previous child, now this is a red signal, a previous child in the family died at 5 years of age from heart trouble. So we don't know whether it is a congenital heart disease, but there is some problem there, right? On your examination, you notice that there is a lower limb contracture at the ankle joint, and you find some hand stiffness and somewhat coarse facial features. So you examine a little more deeply and you find that this child has a moderate hepatosplenomegaly. So here you have a child with a lower limb contracture, some little hand stiffness, and somewhat mild coarse features. So how does one look at there is facial dysmorphism? You look at both parents and then you look at the child, or in case if the parents are not available, then you can always look at their photographs, right? The child's growth, however, is normal. Now, minute you have this, you would really look at whether there is a short stature and whether what is happening with her height. And you find that her growth is okay, but her examination is also normal, right? So which are the next steps that one would think of to do? Would you do an abdominal CT because there is hepatosplenomegaly? Are you thinking in terms of a hematological cause, or are you thinking of TB? Are you do because there is this mild developmental delay? Are you going to look at the MRI? Or would you do because there is dysmorphology, some chromosomal analysis or genetic tests of karyotyping? Or are you thinking of a storage disorder with the hepatosplenomegaly and the thyroid function test because of the coarse features? So, are there any answers in the chat box, Kuntala? So there is this question. So what are the next steps that one would do to approach this child further on in terms of testing?
Right. Let us wait
No.
for. Can we wait, ma'am, for a
Yeah,
minute?
we will. Yeah, we'll
Yeah.
wait. If you want, we can go back to the case. Do we want to go back to the case and then, yeah, let me go back. So again, 2-year-old and uncomplicated pregnancy and delivery. Neonatal period is uneventful. She sat without support at 8 months, pulled to stand at 12 months, and walked since the last 1 month. So about 1 year, 11 months. She has a 10-word vocabulary. So about a year old or something, or year 2, 3 months, is able to drink from the cup and feeds from spoon. There is this history of a, a death in the family, previous child. This child is born of non-consanguineous marriage, and this death was because of some heart problem. You notice that the child is a little stiff, somewhat coarse features, hepatosplenomegaly, and lower limb, mild contracture at the knee. Her height is okay, and other examination, cognition, ADL is uneventful. So, what would your next steps be? Would you do a CT for the hepatosplenomegaly? Are you thinking of a hematological condition? Would you do an MRI for a developmental delay? Because there's this mild delay is there, so you want to look at the MRI because there is coarse features, whether you want to do a thyroid test or a chromosomal or karyotyping, or would you think of a storage condition? Any answers? So the correct answer for this would be D. That is because of the enlarged liver and spleen and the co-species and the history of death in the previous child from heart trouble. This is probably a CP mimic. So it is not because of a, so I can see some answers here. Yeah,
Yes, ma'am.
yes, that's correct.
There is answer D option that is correct.
Right, that is correct. Yeah. So this is what we would do. So, right. Yeah. That is the correct answer. So we are thinking more of a storage disorder, and her joint contracture, hand stiffness can be explained because of abnormal metabolism rather than a CNS deficit. So this is absolutely how you would approach a child with, say, a developmental delay with cerebral palsy, and so essential to rule out a CP mimic, right? And I think this was my last slide. Yeah. So if there are any questions, I would be happy to take them. So as I
Ma'am,
said,
can
yeah,
we give some few minutes if
yeah,
Yes, ma'am.
sure. So just as to say that, for all conditions, we should not be, for all developmental condition, neurodevelopmental conditions, we should always think of a comorbidity always being present in these children. As I said, vision, hearing, swallowing, your fine motor movements, hand functions, which are there. Because as these children grow up, the motor skills eventually mature with age. But what is remaining or the residual is the language which always persists. And these are the ones who, as we saw in the previous presentations, previous sessions, that they can have, minor in our terms, minor neurodevelopmental conditions, but in terms of the parents, they are suffering equally. So once that life and death situation or the mortality bit is tackled and the NICU, etc., and when the child kind of recovers and you're so happy that, HI is stage 2 or 3, and, child is walking and all, but they may land up with these minor neurodevelopmental conditions. Like, as I said, the language delay may be there, or the swallowing could be there, or they can land up with DCD, which we saw in the previous presentation, developmental coordination disorder. As they go for academics in school later on, they can have a cognitive delay, so borderline intellectual functioning, learning disabilities, or their behavior. And in children with cerebral palsy, you can have a lot of hyperactivity also present, or they can have autism later on, right? And always rule out mimickers or red flag, because their treatment can really change the course for that particular child. So in terms of diagnostic testing for children with cerebral palsy, the gold standard all over is BSID, or the Bailey scale for infant test diagnosis. right? And but they are now available in India. In fact, we have the four Baileys, the fourth version of Baileys now available. It is available for payment online, and the company which sells out the Bailey's test does do a, which is Pearson, does do a training pan India. Uh, so there is a training which is there for 2 days and for a particular fee, and then the kit can be purchased. The issue with Bailey's is that it is a very intense test and it takes some time. So it would take at least an hour or hour and a half to perform the Bailey's. So it is very labor intensive and it takes really quite a bit of time. And in our busy OPD, I always find that the TDSC is very interesting because, it comes with the age and there is a horizontal line and you have the x-axis and y-axis and you look at depending on the age given of say from 0 to 5 years of the child with the and on the uh, uh, horizontally it is placed which are the milestones that the child has to gain. And if you use a ruler across that, and depending on the age of the child, what milestone he's achieved, anything which is on the left side of your vertical scale is what the child has achieved, and right is what is desirable. So you immediately come to know where the child is located at in each domain, and you can know how much is the delay. So it is a pretty easy screening tool. The DMCD also, which is there, as I said, it is a 1 day training program, can tell you more intensely and also offer remedial measures or solutions to the child's parents that what is to be done for this particular delay before, for 3 months, what they can do at their end. Sometimes it is because of deprivation and just lack of attention to that child. So if there is more environmental stimulation given, and then you look at this child after 3 months, you want to know whether it was the environmental factor or there are organic factors for the delay. And after 3 months, if you find that the screening is still very much failed, or the child is still developmental delay, then one can go for the diagnostic test and start with the intervention. The other tool that we use commonly for as a diagnostic tool is the DASI, that is Developmental Assessment Scale for Indian infants. And this is also pretty much used. However, it's not upgrade. It's culturally very acceptable to Indian population, but it is not upgraded since quite some time. So, I find that Indian children with each generation, the motor skills are really getting very much advanced compared to what we had. We are we have traditionally taught in Nelson's or in other textbooks. So, if there are no questions, should we call it a day?
Dr. Sanjay, are there any questions?
No, ma'am. Kuntala, the questions.
Okay, okay. So we are at the concluding episode of Brain Mantra, which is brought to you by BrainMax Omega-3 supplement containing both EPA and DHA. First of all, I would like to thank Dr. Mona for being with us from first episode till episode 6 and enriching all of us with your wonderful scientific deliberation. And many more such webinars in future we will definitely conduct. And I also thank all our delegates for being with us throughout all the episodes of Brain Mantra. I also thank our medical team, Dr. Sanjay, Dr. Shefali, and Dr. Soumya. And thank you, all of us. And with this, we would like to conclude this 6 series Brain Mantra episode, and wishing everybody a very happy, advanced happy Merry Christmas and a very happy New Year. Thank you.
Thank you. Warm Merry Christmas to everyone and Happy New Year and new learnings in the new year. Thank you very much.
Thank you so much, Dr. Mona.
Thank you very much.
Thank you, thank you, thank you.
Thank you so much.
Kuntala, please stop